This episode of Common Health is brought to you by Reg Lantern. Reg Lantern is a straightforward and easily understandable software platform built to assist community health centers in staying compliant so they can focus on serving their patients rather than paperwork. For health centers that are serious about achieving, managing, and maintaining compliance, Reg Lantern provides a comprehensive approach and is an affordable and valuable solution. Reg Lantern can help your health center. Contact them today at reglantern.com. That's REG, as in regulations, lantern.com. For special discounts, mention that you heard about Reg Lantern on the Common Health podcast.
Hello, and welcome to Common Health from the Virginia Community Healthcare Association, or VCHA, or what we're also known as is VACHA. I'm Tracy Douglas, VACHA's Chief Executive Officer. On Common Health, we're amplifying the voices of community health, both those who give care and those who need it. We again have another fantastic story. We've got a guest here by the name of Sara Cariano. Cariano, yeah. And she's from the Virginia Poverty Law Center. And I came to know the Virginia Poverty Law Center through a relationship that the Virginia Community Healthcare Association has with the Law Center. And they are doing some fantastic work here in the state of Virginia, working with many Virginians as those who are looking for insurance coverage. If someone is sick and they don't have any insurance coverage, it's Sara's organization that really does a lot of outreach to help many folks here in Virginia get the kind of insurance coverage that they need. I'm going to talk to you a little bit about Sara and who she is and what she does. She's been at the Virginia Poverty Law Center now for nearly 8 years, right? Right?
Yep.
And she functions as the policy specialist and lead navigator at Enroll, Virginia Poverty Law Center. Enroll Virginia, just for the listeners who don't know, is a network of community-based organizations committed to helping Virginians access high-quality, affordable health coverage. And Sara attended the University of Richmond for her undergrad and Virginia Commonwealth University for her graduate degrees. You have 2 degrees, right?
I do. Yep. Social work and public health.
And are you a Richmond native, Sara?
I'm not. I'm a transplant, like many you are. Many of our students are. I'm originally from New Jersey.
And you stayed here in the Commonwealth.
I did, yeah.
Okay. So then for those like me who didn't grow up in Richmond, I'm a transplant myself. I'm always looking for great places to eat because I'm a local foodie. You got a place you can recommend to me here in Richmond, Virginia?
Yeah, my husband and I really enjoy Adara, which is up in Jackson Ward. It's like Basque style tapas. It's really tasty. We really like it a lot.
Okay. Well, I am adding that to my list. So thank you for sharing that. Sara, to start us off, I do want to ask you a question about Enroll Virginia. Can you give us, actually, you know what? Let's step back a little bit. Talk to us a little bit about who is the Virginia Poverty Law Center?
Yeah, so VPLC is I think 41 years old. I think our 40th anniversary was last year. And we kind of have a 3-pronged mission. One, we are a state support center for local legal aid organizations. So we do a lot of training and case support, or the attorneys on staff. I'm not an attorney, obviously, as we said, for local legal aids. And legal aids are kind of the entities that provide free civil legal help for low-income Virginians. So it's kind of the civil counterpart to a public defender, but it's not funded in the same way. So they do a lot of housing work, they do a lot of some employment work, family law, things like that. the public and a lot of public benefits, which is kind of where my role comes in. We also do state level advocacy. So we do a lot of work at the General Assembly where we advocate for things that we believe will help low income Virginians and break kind of the cycle of poverty that does exist. And then we also do some litigation. And so VPLC was, part of the litigation against the Virginia Employment Commission last year in conjunction with some private attorneys and Legal Aid Justice Center. So those are kind of our three pieces. And then Enroll Virginia is one of our kind of more direct service programs that VPLC has. So with the implementation of the Affordable Care Act, there was the creation of these programs called the Navigator programs that are funded through kind of fees that insurers pay to offer plans on the health insurance marketplace. And we were lucky enough to be awarded one for the first year back in 2013. And so we have been a Navigator program since that time. Virginia is moving to a state-based exchange, so we're actually now funded by the state versus the federal government, but it's those same health insurer user fees that fund the program. And we mainly work with the individual market, those ACA plans, as well as Medicaid. And back in 2019, when Virginia expanded Medicaid, our Medicaid work increased a lot because we had a lot more eligible individuals who previously could not get coverage, who, as of January 1, 2019, kind of had this option for coverage.
So, as I had mentioned to our audience, Sara, I became familiar with your group when I joined the Virginia Community Healthcare Association and learned that the association had a contract with the Virginia Poverty Law Center for the Enroll Virginia program. So what kind of things do you do through that contract, as with other collaborators as well?
Yeah, so our main collaborator with that are the certified application counselors who are at most of the federally qualified health centers, who are great partners. So we have about 23 navigators right now, and we're a statewide program. So obviously we cannot serve all of Virginians. So very early on, we took it very, very seriously, found it very important to build really strong relationships with other kind of community assisters, other folks who are doing similar work or kind of parallel work, so that we really could build a strong statewide network. So for instance, we don't have a navigator in Eastern Shore, and so a lot of times we'll refer people to the Eastern Shore Rural Health Center because they have some really strong CACs there who can help enroll folks. And then in conjunction with that, with our partnership, we really see ourselves also as a resource center. So we provide a lot of case support when there's just really complicated cases, or interface with the Department of Medical Assistance Services, which is the state agency that administers Medicaid. If we need help kind of maybe shaking loose a case that's gotten a little stuck at a local DSS, we'll say. And then, if you look at Medicaid in Virginia since 2019, there's actually been a fair bit of shift in terms of our eligibility rules, just with expansion and some changes in immigrant eligibility, some changes in postpartum coverage, the types of services that are covered have expanded some. And so we also like to try to make sure that we are getting that word out to the assisters, who are then getting that word out to the Medicaid enrollees or their communities, and making sure folks can get in and know what they're eligible for. So do a decent bit of just like training and trying to make sure we're very, very up to date on what's going on, so that our network across the state is also very up to date on what's going on.
So, I think it's important that we talk a little bit, Sara, about what's getting ready to occur here in the Common Virginia, and not just the Commonwealth, all the states here, once the Public Health Emergency Act ends. We're calling it the unwinding, right? The Medicaid unwinding. Can you just talk a little bit about what happened during COVID, right? The Commonwealth of Virginia had expanded Medicaid, meaning that, we opened it up so that more individuals here in the state could access healthcare services through being accepted into the Medicaid program. And it was interesting because that expansion happened really kind of at the beginning height of COVID. And then here comes the federal public health emergency effective. And then all of a sudden, Medicaid enrollees here in the state just, grew and grew. So can you talk about that? What was that happened during COVID? And then talk about this unwinding and what does that mean for individuals here, not just in our state, but other states? And then what does that mean for our healthcare providers in this unwinding?
Yeah. So to take a step back, I will say back in March of 2020, Congress passed and the president signed the Families First Coronavirus Act. And in that, there was a provision called a maintenance of effort provision for Medicaid. And it was directly tied to the ongoing COVID-19 federal public health emergency. And it had a couple provisions in it. It said states had to cover COVID testing, treatment, and vaccination when they came out, because at that point they weren't around yet. We couldn't increase copays or put new copays in. And the really most impactful provision was it said we could not terminate anyone's coverage until the end of the federal public health emergency. And obviously the government knew that this would increase costs to state, right? Because states pay part of the Medicaid program. The federal government pays the other part, which is called your federal match or your FMAP. And so they said, because we want you to do this and we want to make it kind of worth your while, we're going to give you an extra 6.2% of your FMAP. And so Virginia is a state a commonwealth where we pay 50% and the federal government pays 50%. So during the federal public health emergency, the federal government is now paying 56.2% of our Medicaid costs. CHIP, it's actually a little bit higher match. And so, but the numbers kind of track where we are getting more CHIP funding, or we call it famous in Virginia funding, than we were prior to the public health emergency, and then we will once the public health emergency ends. The few kind of exceptions, so if someone moves out of state, because Medicaid is a state-to-state program, you can terminate them. If someone passed away, we could terminate their coverage, obviously. And enrollees had the right to request that their coverage be terminated, right? So we didn't force people to stay on Medicaid if they said, I don't want this anymore. The impact is that our Medicaid rolls have expanded to over 2 million people, which is really, really massive. So back when we were advocating for Medicaid expansion, right, for the adoption of this Affordable Care Act option where we could cover adults if they were not parents, if they did not have a disability, if they were not pregnant. We just wanted to cover adults who were low income. It was estimated about 400,000 individuals would enroll in that category. We currently have over 600,000 people enrolled in that category. And so that's a lot of people in that category. It's over 2 million people in Medicaid as a whole. We have a lot of people in Medicaid right now. Usually for Medicaid, you are required to go through an annual renewal process. We need to ensure that each year you are still eligible for the program to remain enrolled. Enrollees also have a requirement to report changes. So if mid-year in that period, your income goes up, you're required to report that change. And if your income has now gone above the income eligibility level, you'll be disenrolled from Medicaid. So all of that was put on pause, right? And so we had this impact of COVID where a lot of folks, especially early on, maybe had disruption in their work, they had reduced income. So they were newly eligible for Medicaid. So we had some folks who were newly eligible who were coming in. We also had Medicaid expansion. So we were still kind of getting the word out about Medicaid expansion and making sure folks knew about it and knew like coming in. And then we paused all terminations. And so people who were then going back to work and their income was going back up, or maybe they aged out of the children's category and wouldn't be eligible in an adult category, were all being kept in Medicaid. And so we have a lot of people, which, Virginia, just to take a little side note here, was one of the few states in 2019 and 2020 who had a reduction in our uninsured rates. So we had more insured Virginians than we did in the years prior. And that was an anomaly compared to the rest of the country. Our children's uninsured rate is down around 2.1%, which is phenomenal. I mean, it's amazing. I mean, I've been doing this work for 8 years and it blows my mind. And I know folks who have been in it much longer than me are just like, how do we keep this? And I think that brings us to kind of what the unwinding is, right? So when the public health emergency ends, states have to return to their normal processes. So DMAS is saying our return to normal. We often hear and call it the unwinding or the end of continuous coverage. All of these are talking about the same thing. And what it means is that we just have to go back to doing our annual renewals. We have to just ensure that the folks who are on Medicaid are still eligible. But it's going to be quite a bit of work because our caseload has gone up. Our local Department of Social Services, who do all the case management for Medicaid, continue to be overworked and underfunded. And so their caseload has gone up about 40% from what I heard at one point. And they're going to have to go through all of these cases and do all of these renewals. The federal government has said that they will have 12 months, and so it will not all happen at once. It will not be like the public health emergency ends and the next day 2 million people are going to get a renewal. The state has 12 months to initiate and 14 months to finish renewals. A lot of them will be done through different processes. So a lot of our categories, the state at least first attempts to do an automatic renewal. And so if someone can be automatically renewed, they will just get a notice in the mail that says, hey, you've been renewed. Here's your new renewal date. For those folks who that either can't go through the automatic renewal process, say the data that the state is checking is different than what they have on their record, and so they need a verification, or anybody who's in a category of Medicaid where they have an asset or a resource test. So these are our 65 and up individuals who are in Medicaid due to a disability, anyone receiving long-term care. They will also get kind of a paper renewal where they have to return information because those resources at this point in Virginia can't be checked automatically. And so they have to do this kind of manual process for those folks. And I do think it's worth noting, because Tracy, you kind of pulled this out already, that because expansion went into effect in January 2019, and the public health emergency maintenance of effort requirement where we couldn't take anyone off the rolls went into effect March of 2020, very few Medicaid expansion enrollees had actually hit their first renewal date at that point. And so there's a lot of people in that category who have actually never even been through a Medicaid renewal, may not know that it's a requirement to maintain the coverage. Right. And so, we really want to make sure these folks are aware of what's going to happen. It's not anything new and different generally for Medicaid, right? We're not adding new requirements. But it is returning to this normal process, but returning with so many people is just going to be a really large lift for the state. And then, all the folks across the state who are helping individuals who are enrolled in Medicaid. I'm certain it's going to impact providers, because a lot of time people don't know their Medicaid was terminated until they go to get a prescription filled, or they go to get an appointment or go for an appointment. And all of a sudden they're told, oh, you don't have coverage anymore.
Right.
And that's not good for the individual, and that's really hard on the providers too.
Well, I think one of the good things, though, for those individuals who use a federally qualified health center, an FQHC, during this time of the unwinding, the good news is that FQHCs have a kind of stopgap in place, right? So they're not going to stop seeing their patients, because they verified that their insurance is no longer in effect. These FQHCs have systems in place where they work with the individual, because FQHCs accept patients no matter what their ability to pay is. And so we feel really good with the upcoming unwinding that, FQHCs will be in a good place when it comes to taking care of continuing to be able to take care of their patients, and patients feeling okay. They've got that assurance, right, that they'll be able to still continue to see their provider because of the required contingencies that are in place at FQHC. So I think that's one of the great things about this. But on the other end, though, Sarah, right? we potentially could have situations where individuals, like you said, may not know that their coverage has ended until they actually seek that service at the time. And it's interesting because when I was reading some of what's behind the expansion and then the COVID, and the roles, the Medicaid roles growing here in the Commonwealth, I thought about it. What did people do for healthcare service or insurance before the Commonwealth of Virginia expanded? And I'm not sure if you really have the answer, but I'm curious, how did people get their healthcare coverage if they did not have access to insurance through the exchange or through the Medicaid expansion?
Yeah, so I mean, it's a really great question because the answer is hopefully they did if they could, but many couldn't. Obviously the federally qualified health centers were a huge part of that safety net, but the capacity just wasn't there because there were so many uninsured individuals. So with the Affordable Care Act, the subsidies to purchase insurance that help make it affordable started at 100% of the federal poverty line. And the way the bill was originally envisioned was that Medicaid expansion would cover adults below that. When the law was brought before the Supreme Court said states could not, or the federal government could not force states to expand their Medicaid program in that way. And so it became a state option. And so for the first several years that I was a navigator, 2013 through 2018, we would regularly see individuals who we'd say, oh, you make too little money to get help, right? We called it the Medicaid gap. There are still several states that have a Medicaid gap. Texas and Florida have some of the largest uninsured rates because they have very large populations and a lot of folks who would be covered were they to expand Medicaid, but they've chosen not to up to this point. And so we would often refer people to the federally qualified health centers, the free clinics, as well as hospital charity care programs. But we all know it leads to, overutilization of emergency departments. It leads to people avoiding care until they're very, very sick. And all of these have really negative consequences. We also saw when we expanded Medicaid, we had more kids come into coverage, right? It was this woodworking effect where, the parents are getting covered. Now we're getting more kids in the coverage programs as well. And that has there's a lot of evidence that both having the child covered and the parent covered actually helps with like educational attainment and economic attainment and all of those things. So I like to say one of the best moments in my career was the first time I got to tell someone, you're in the Medicaid gap. It was like December 2018. But next month, there's coverage for you. Because it's so hard to just have to sit there and tell people, I'm sorry, you just don't. Can you work 5 more hours a week or a month to get your income up to the point where you can get that assistance to help you purchase that coverage? Medicaid expansion is just, I think it's hard to overstate the positive impact that has had on the lives of literally hundreds of thousands of folks in Virginia and then, millions nationwide.
Right. I was, last week I was attending an event at one of our federally qualified health centers, Rockbridge Area Health Center, and Senator Tim Kaine was there, as well as some, a state legislator. And one of the things, and that was Cree Deeds, and one of the things that Cree said, and I'm not going to say it exactly, but it was so profound to me. It really just kind of stuck with me. And even though I knew it, it was just good to hear it from someone else. But, at the end of the day, part of the decision why, Representative Deeds and others made the decision here in the Commonwealth to approve expansion was because, at the end of the day, it fiscally makes sense because we keep people healthy, right? We keep them at work. And we keep them working because they're healthy, right? And so if they've got that coverage, then folks are more inclined to seek the care that they need, to take preventative steps if they're, hypertensive, or they have diabetes, or they're just not feeling well. And now with the onslaught of being able to see your doctor via telemedicine, right? Like how you and I are talking, you're in one state and I'm in another state, as we're doing this show, and we can see each other virtually on our computer screens. I mean, that's great, because it keeps people at work, and they don't have to worry about whether that doctor bill or that hospital bill or that urgent care center or that FQHC service is going to be covered, because, now they know they've got that coverage. So it just makes sense, to, at least from where I sit, I think it makes sense to keep people insured, because after all, we're helping keeping them healthy, and we're keeping them at their jobs, right? We're allowing them the opportunity to be able to make an income because they are focused on their health, right?
And and just a finer point on the kind of the state fiscal impact that, I talked earlier about how that federal match for Virginia is usually 50-50. For Medicaid expansion, it's 90-10. So the federal government is actually footing the bill for 90% of the costs for Medicaid expansion. And we use a hospital assessment in Virginia to pay for the remaining 10%. And so we're getting all of these positive impacts, but really the cost to the Commonwealth for this category is very, very minimal.
Mm-hmm.
And so the economic impact is, it's helping the Department of Corrections, because Medicaid can pay for hospitalization for individuals who are eligible for Medicaid but incarcerated. It helps. It helps kind of across the board in all these different areas. The more you look at it, the more you realize how it, just getting health coverage impacts every aspect. Being able to access care impacts every aspect of your life.
Right.
So it's good that we are getting more people into care and coverage, right?
Right. And it's interesting, you reminded me of something, as the association, right, representing federally qualified health centers here in Virginia, at the end of the day, it helps to cover the cost of care, right? And so that means that providers get paid, and health centers are able to reinvest in their services and potentially expand services and locations to allow more Virginians to come, because their bills are able to get paid because Virginians are covered. So you're right. There's just so many different ways this benefits the state economically, to make an investment in your citizens and help cover them, so that they can all stay healthy. Sara, one other thing I'd like to also learn from you is, what advice would you give to individuals who are listening today to our show and listening to you? And we talked about the unwinding that will occur. We don't know when, but we know it's coming. What would you say to individuals who are covered, and, as a way, I guess, to prevent a lag in their coverage, right? What's your advice for them?
Yeah, so I think for enrollees, for individuals who are in Medicaid right now, the most important thing you can do is make sure the state has your updated mailing address and contact information. So the state does all their notices and communications through the U.S. Postal Service. So if you have moved and don't get a notice that's saying, oh, please take this action, you're going to lose coverage because you didn't take the action. And I know there have been a lot of folks who have moved since March of 2020. We're also seeing, a spike in evictions right now. And so I think we are continuing to see this kind of churn in residents. And so just making sure that the state does have that kind of updated contact information for you. I've also, for kind of the next level up, for organizations who work with Medicaid enrollees, I'm encouraging them to kind of look at their population and think about the folks who are at higher risk if they lose coverage. and then who are going to have more difficult transition points. So, for example, Medicaid expansion will only cover individuals up to through age 64. Because at age 65, most people are Medicare eligible, and they have to qualify for Medicaid, because you can be dually eligible in Medicare and Medicaid in our age-blind and disabled category. But Medicaid expansion's income limits are 138% of the federal poverty line, and there's no asset or resource limit. The age-blind disabled, which I'm sorry, I try not to use acronyms, but I'm probably just going to say ABD from here on out. So I defined it. It's an 80% of the federal poverty line income limit. And there is an asset resource limit for an individual of $2,000 or $3,000 for a couple. And so there's a pretty big gap in eligibility for Medicaid. And then if these people, have been in Medicaid expansion and getting full coverage, so maybe didn't enroll in Medicare during their initial enrollment period, there's definitely like a dance and a jig to make sure you're getting into Medicare and getting that lined up. Right. So for me, I look at that kind of small subset. I'm like, that's going to be a much harder transition into coverage than someone who's 55 and has had their income go on up and needs to get into employer coverage. There's, still deadlines there with SEPs for employer coverage, special enrollment periods for employer coverage. But that Medicare dance is really complicated. And so if you are an organization that works with a lot of these individuals or individuals who are getting long-term care, and just making sure that there's no gap in coverage there, because that's a really vulnerable population. Obviously, if you're needing long-term care, you cannot afford to have a gap in coverage. Start making a plan now for how to approach that transition when you're going to have to transition at the end of the public health emergency. Open your mail. Many people come to I cannot tell you how many people come to my office with like unopened mail, and they're like, I don't know what happened to my coverage. And I was like, well, one of these letters probably gives you a clue.
Right.
Please open and read your mail, and then call, the CACs at your federally qualified health center, call a navigator. If you have questions about what the notices say or questions about what you should do to keep the coverage. And then I think, just knowing you just kind of peace of mind. Medicaid enrollment is year-round. If you lose coverage, you can always reapply. For Medicaid groups, even if the application takes a bit to process, it automatically goes into effect the first of the month that you applied when you're approved, obviously. And you can request up to 3 months retroactive coverage, assuming you're eligible during those months. And so if someone, finds out that they don't have coverage while they're in the emergency department, you get a really big bill if you're uninsured. You go to the emergency department, right? You can still apply through Medicaid and still have that bill covered. Again, it's getting a provider to submit it again, and it's complicated. So avoiding a gap is always best, but there is kind of at least a short retroactive period and peace of mind that you can take advantage of. And so knowing that exists, I think, is helpful too.
Sara, I want to end this by saying and really asking you, why do you do what you do?
I think I'm very lucky in my job. So as I said, I have a social work degree as well as public health degree, and I've always been more drawn to like the macro policy than doing clinical work. God bless the clinicians, man. I don't think I'd be very good at it, but I have an amazing amount of respect for them. But because I do the enrollment piece, I still get these one-on-one people interactions where I can see the impact of the work we're doing. And then I get to do this like policy work to try to make that better and broader. So obviously it's incredibly rewarding just to be able to help people in that manner. And on a more core level, I think it's just when someone is sick, they should be able to see a doctor. Like that's just kind of a core base belief that I have. If someone is sick, if someone's kid is sick, they should be able to go see a doctor without worrying about losing their house or worse, or waiting until they get really, really sick and then the outcomes are worse. It's just, it's just such a basic kind of humanity level function that I just, it's hard to believe anyone disagreeing with that.
Yeah, I guess I think at the most basic level, you kind of say to yourself, everyone really should be able to access healthcare services when they need it. And it's, it's kind of hard to feel that others don't feel that way. And so to be in this space, where you're working with, doing wherever you can, right? And working with organizations where, like yours and the members that we represent, federally qualified health centers, that, the only thing we see is making sure we bring the health care, right, to Virginians. We're bringing it to them. And to not be able to make that happen, I can't work it through my brain. I can't work it through my brain, but that's just me, so, but yeah, I feel the same way that you do. So, I just want to say thank you, Sara, for taking the time to talk with us and sharing what you shared. It's really important stuff, listeners. For those of you who are Virginians, and you are, on a Medicaid insurance plan, please, 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 like Sara said, check your mail, reach out to Virginia so that you can ensure that your coverage continues. And for those of you who have normal, who have what we call commercial insurance, we're not going to call it normal, but we're going to say commercial insurance, always stay up, right? I always tell people, always stay up on what your coverage is, right? And make sure there is no lapses or gaps.
Yeah, I will say the one thing about health insurance that is true no matter what kind of coverage it is that there are deadlines and they are important. They don't move. So if you miss them, it can create some really hard and complicated situations. So always knowing the deadlines and adhering to them is incredibly important.
Totally agree. You are so right. So Sara, thank you. And listeners, thank you for once again for listening to this podcast. And we will, of course, have more shows. We've got more future shows coming down the pike, just like the one that we did here with Sara. So Sara, thank you. And listeners, have a great day on purpose. I want to thank my guests for joining us today. And thank you to all the listeners for tuning in to Common Health, brought to you by the Virginia Community Healthcare Association. If you enjoyed this episode and you'd like to help support Common Health, I encourage you to hit the subscribe button, share it with others on social media, leave a rating and review, or visit our website at www.vcha.org. This is Tracy Douglas. Thanks again, and I'll see you next time.